Thank you, Jeff. It's great to be here, and this is a fascinating topic. Let me tell you where I'm coming from on it. I mean, I'm not an expert in marijuana or cannabis. My research is focused on memory and aging and Alzheimer's, and particularly how to detect it early and how to intervene early to have the best benefit. But I also see patients, and a lot of my older patients are talking about their use, and I don't know quite how to advise them. So, and the more I've read and heard about marijuana and cannabis, the biological components of it offer some opportunities to help our aging population. So what I'm going to do with you is share with you kind of a perspective of a novice coming at this field, except, I heard about it when I was younger. I think I might have had some secondary smoke experiences. I think some of our past presidents didn't inhale, I'm going to say that. But it's a fascinating area, and in a way, it's a bit like the Wild West, that there's so little we know. That makes it very challenging, but it also makes it very exciting. So to begin with some acknowledgments of my research support, potential conflicts of interest, and so forth. And then what I'm going to try to do is ask and answer 3 questions. Is there evidence that cannabis has any kind of therapeutic benefit for older people? What are the adverse effects we've got to be concerned about? And where should we focus our research efforts? So, I'm sure you've heard things like this before. I mean, there are people who are terrified of the reefer madness, and of course that got us into trouble in terms of the law and some of the things we're suffering from today, the legal restrictions and study. And then there are people on the other end that, this is going to be the fountain of youth, it's going to cure everything. And as trying to be a careful scientist, I'm somewhere in the middle. I don't know. I'm an agnostic, but I want to study it and understand it. So to kind of give you some general background, we've got an age wave right now. We've got 76 million baby boomers who are coming of age. In 2011, they started turning 65. If the trends continue, we can expect 84 million of them by 2050. And a lot of these boomers used recreational marijuana in their youth, and they've returned to it later in life when it's become legalized in some states. And what's interesting also is many of these seniors report that they still have a sense of shame or guilt, or that they're doing something wrong, even though it's perfectly legal to use it. Also of note, what's quite interesting is that for people who use marijuana for medical symptoms, 30% are 50 or older. That makes sense because we know as we age, we're more likely to experience physical illnesses and chronic pain. Also a lot of insomnia in older people. Now, older adults don't comprise a huge segment of the population that's using marijuana, but it's the fastest growing segment. And I just looked at a few recent studies showing that in the past few decades, there's the greatest increases in the 50-plus age group and even greater in the 65-plus age group. And you can slice and dice these statistics, but the bottom line is the trends are that these older adults, about the annual increase is about 10% per year for middle agers and 15% per year for older folks. And if you look at the map of where marijuana is medically legal or recreationally legal, it's really penetrated a lot of our states. And I predict if this trend continues, which I suspect it will, this increase in use among older adults will increase even more. So in my review of what we know about the medical effects or potential therapeutic benefits of these products, there was a nice review by Abrams just last year. And there seemed to be substantial evidence for pain, for treating that, moderate evidence for sleep, and I'm just focusing on those indications that I think would be quite relevant for our older population. Less evidence for anxiety, PTSD, appetite, weight change, and insufficient evidence for many of these other areas, such as epilepsy, neurodegenerative disorders, and so forth. Now, in a moment, I'm going to make some arguments as to why it may have a place in helping neurodegenerative disorders. But right now, I want to focus on two areas I think are very important for older people: chronic pain and sleep. And this is relevant to the area I'm particularly interested in, and that's neurodegeneration and memory, and I'll show you why. So pain is, aging is a pain. We have a board of directors for our longevity center. Art Linkletter chaired the board for many years, and he wrote a book called Aging is Not for Sissies, because it is challenging. And about a third or a fourth of older people have chronic pain. And as they get older, they're more likely to experience the pain. Pain increases a lot of risks for falls, functional impairment, even cognitive decline and dementia. And neuropsychological studies show significant deficits in various cognitive functions that are associated with chronic pain. So there's clearly a connection between pain and the brain. If you delve a little deeper, there have been some studies looking at large cohorts of older people. One study of 10,000 people living in the community who were about 73 or so. 11% had persistent pain at baseline, and the persistent pain was associated with more rapid memory decline. And after 10 years, the accelerated memory decline led to higher risks for problems handling your medication, inability to handle your finances, developing dementia. So all these functional impairments are tied in to chronic pain and memory loss. In terms of medical cannabis and geriatric pain, there was a prospective study of over 2,700 patients, on average 75 years of age, and they received medical cannabis for conditions such as pain or cancer. And after 66 months, 94% reported reduced pain levels. Now these pretty much all the studies I'm going to be talking about are not what I think of as the holy grail or gold standard, double-blind placebo-controlled trials because of the legal restrictions. But the observational studies do inform us, and they help us with pilot data that we'd like to be able to get these randomized controlled trials going. So the question, I know this, I imagine this was discussed earlier. I don't know how much it was discussed in terms of the older population. What is the connection between marijuana use and opioid use? And there was an interesting retrospective study of over 200 older adults in New York. And this was a 4-month study that they found that 69% of these patients received some relief for their pain. Almost 50% of them had pain reduction. About 20% had better sleep. 15% had benefits for neuropathy, and 10% for anxiety. 32% had a reduction in their opioid pain medication use. And in another study, this prospective study that I mentioned earlier, the 2,700 patients or so, after 6 months, 18% stopped using their opioids or reduced their opioid use. What about sleep in older adults? This is a pretty common problem. I see a lot of patients who are taking Ambien or other medicines for their sleep, and that's a whole another discussion. And about two-thirds of older adults report some kind of insomnia, and there are a variety of risk factors for that insomnia, such as older age, sleep medication, daytime sleepiness, and so forth. Maintaining sleep, difficulty initiating sleep, and early morning awakening are the most common concerns in this group. Other sleep disturbances, less common, would be sleep apnea and restless leg syndrome. So what about cannabis and sleep in these populations? One retrospective analysis showed significant decrease in reported time to sleep after the use of cannabis in those with and without reporting sleep difficulty. So even the people who didn't complain about their sleep noticed their sleep got better. Middle-aged adults more likely to report using medical cannabis for insomnia, while the older adults are more likely to use medical cannabis for chronic medical problems. And in a survey of over 2,900 cannabis users, in the overall group, 80% reported improved sleep, and for the 50-plus group, it was slightly higher, 86% had improved sleep. Now, with CBD, that may have a potential for treating insomnia for older adults. THC may reduce sleep latency, but impair sleep quality when used long-term. That's what the data suggests so far. Synthetic cannabinoids may have short-term benefits for sleep apnea, and CBD has promise for REM sleep behavior disorder and daytime sleepiness. Nabilone may reduce nightmares associated with PTSD and improve sleep in chronic pain patients. Now, there are some data on substitution of medical cannabis for other drugs for pain, anxiety, and sleep. And these are data from the New England dispensary members, over 1,500 subjects in an online survey. And since starting medical cannabis, respondents using the following medicines reduced their dosage. So opioids, 77%, anti-anxiety agents, 72%, sleep medicine, 65%, migraine pain medicine, 67%, antidepressants, 38%. So this is encouraging that cannabis products may be helping with these different conditions. Unfortunately, we don't have control groups to really wrap our heads around what the true numbers are. Now let me shift for a moment. So we've talked a bit about sleep, opportunity there to help older people. We've talked about pain. Now let me talk about cognition and neurodegeneration. So to set the stage, I'm going to just show you a few slides of what I understand to be the issues and how we might address them. So we've got an epidemic of dementia and Alzheimer's disease because we're victims of our own medical technological success. We're living longer than ever before, but age is the greatest single risk factor for developing cognitive impairment. By age 65 or older, the risk is about 10% to have a dementia, which means your memory is severe enough that you need help from others. By age 85 or older, the risk is almost 50%. And it's very costly, and just as the numbers of older people using cannabis is increasing, the number of older people getting dementia and similar conditions is increasing. It could be up to 15 million in this country by 2050. So if you look at a normal brain, let's see, which is here, you see it's nice and plump. If you look at an Alzheimer's brain, it's atrophy. And these insets show you where the amyloid plaques and tau tangles, some of the areas it collects in the temporal lobe and the frontal lobe and other regions. And these abnormal protein deposits define the disease. Whether they cause it or a result of some other process is still debatable. But notice in this normal plump brain, there's an occasional plaque and an occasional tangle. And we've studied this over the years with PET imaging. We invented the first PET ligand that shows these plaques and tangles in living people. And so these studies, this is in normal aging. You see over 2 years, there's no buildup, no red or yellow in the brain. But if people have mild cognitive impairment, you can already see buildup in some of these memory centers. And after 2 years, it gets much worse. And here's a study of someone who had Alzheimer's disease, a lot of plaque and tangle in the brain. And we followed that person to death. And you can see at autopsy, there's a correlation between what we see in the living and what we see at death. And if you look at this computer image of surface projections of 20 scans ranging from normal memory to mild cognitive impairment to Alzheimer's, you can see this buildup in these areas of the brain that we know are affected. And as it gets more red and yellow, there's worse memory. But as the animation loops around, these people who already have plaques and tangles in their brain, they won't get dementia for maybe 10 or 20 years. So we can detect these problems quite early. The question is, what can we do about it? And that's what we're trying to figure out. So if you plot cognitive health versus age, there's really 3 stages that we think about. Normal aging, where we forget where we place our keys. Mild cognitive impairment, where it's a bit more challenging, but people can compensate. When that compensation breaks down, that's when people get dementia. We've got about 20% of older people with mild cognitive impairment. These people have a 10% risk of developing dementia each year. And as I mentioned earlier, about 10% of them have dementia. And we look at potential risk factors and protective factors when we're trying to understand what's going on. And we don't have time to really get into it today, but there are genetic risks and lifestyle risks. For the average person, genetics is not as important as lifestyle. So we've studied a lot of things like physical exercise, good for your brain. If you exercise just 20 minutes a day, you can see your hippocampus will grow over a year period, and it will shrink if you don't exercise. And a bigger brain is a better brain, so if somebody calls you a fathead, it's actually a compliment. And we're learning about mental exercise, so if you do puzzles and you come to lectures like this, it probably protects your brain. These studies were often based on people who went to college, where they had a lower risk for Alzheimer's. We know it's definitely true about UCLA. We're still tallying the results over at USC. But in all seriousness, even if you don't go to college and you engage in lifelong learning, it will protect your brain. Another negative factor is stress, and ways we can reduce stress will be brain protective, and we've done a lot of research in that area. And also diet is important, weight management, and I'll get into that in a moment, why one of the reasons it's very important. Consuming omega-3 fats, which are anti-inflammatory, from fish and nuts are good. Antioxidant fruits and vegetables, trying to minimize processed foods and refined sugars. But we've got a challenge with nutrition, and this is what the evolution looks like. But the good news is, studies done on patients who are obese, who have undergone bariatric surgery, find that after 12 weeks, they have significant memory improvements. And there have been a number of studies trying to understand that, and my colleague and friend Dave Heber was just here. He's helped me with a lot of these studies, but it's quite interesting. If you look at abdominal fat, the central obesity, those fat cells, and these are actually, I believe I think they're CT scans or MRI scans showing you that fat. This is pro-inflammatory fat, so it increases inflammation throughout the body and the brain. And it turns out that central obesity in particular, but obesity in midlife, will quadruple your risk for getting dementia in late life. So that's why I bring up diet and the theme of inflammation, which is very important. We think of inflammation as a normal process. If you sprain an ankle, if you have an infection, that gets going. But if you look in an Alzheimer brain at those amyloid plaques, there's evidence of inflammation, activated microglia, cytokine, and so forth. And a lot of data is now showing us that anti-inflammatory strategies like getting a good night's sleep, physical exercise, consuming omega-3 fats, this could be brain protective. And the mechanisms, we don't know exactly what's going on, but there's definitely aging, physical inactivity, it could be vascular disease. They trigger monocytes to increase pro-inflammatory markers that actually get through the blood-brain barrier, and there's neurostimulation, amyloid plaque and tau tangle accumulation. Genetic risk is probably implicated to some degree. So it's an interesting issue, and just as an aside, the field in Alzheimer's disease have been huge efforts to try to clear that amyloid out of the brain. Basically failed. And so we're looking for other disease mechanisms, and I think there's a lot of evidence showing that anti-inflammatory, antioxidant strategies may make a difference. And the way we go at this is we try to intervene early. We think it's going to be easier to protect the healthy brain rather than try to repair damage once it's significant. So now let's get back to that decline curve, and I showed you these 3 stages of neurodegeneration or cognitive decline. So let's look at some of the evidence in terms of intervening early on in normal aging and mild cognitive impairment. We've done a number of studies in this. NIH supported this study where we took An anti-inflammatory drug, Celebrex, gave it to the worried well, people forgetting where they put their keys. After 18 months, they had significant improvements in cognitive function and significantly more efficient brain function in the frontal lobe. You know, it's great that this is helping people, but this was a small study, and other studies have shown that anti-inflammatory drugs, when there's a lot of amyloid in the brain, could accelerate cognitive decline. So there's kind of a tipping point where these interventions may be helpful or harmful. We don't have a biomarker to tell us that. So we've been looking, and also anti-inflammatory drugs have lots of side effects. So we're looking for safer ways to reduce inflammation. So we did a clinical trial last year on curcumin, which is a spice. 5% of turmeric contains curcumin. In India, there's a lower rate of Alzheimer's disease in 70-year-olds than there is in other countries. But more importantly, the studies in the laboratory show you that curcumin is anti-inflammatory, antioxidant, anti-amyloid, and anti-tau. So we decided to study curcumin in these people with normal aging or with MCI, and had a very significant results where we found a very strong effect size for memory, for attention, a variety of memory functions. We even saw a signal in terms of plaque and tangle deposition in a couple areas of the brain that control memory and mood. We saw a mood effect, but these people were not depressed, and there was not a between group difference between the placebo group and the active ingredient group in terms of mood, although other studies have shown that. We did a study with pomegranate juice, a couple of them actually. One where we looked at functional MRI in subjects performing a visual memory task, and another larger randomized controlled trial over a year's period, and saw significant effects with pomegranate juice. Again, very powerful antioxidant and anti-inflammatory, and just shows you some of the brain regions that showed a significant difference between the pomegranate juice subjects and the placebo subjects, and just the effect in visual memory that we saw for these subjects over a year. And so that leads to the question, could cannabis protect our brains as we age? So let's look at that for just a few moments. So cannabinoids may act on CB1 cannabinoid receptors in the hippocampus. Hippocampus is a very important memory center underneath the temples where we form memories. THC activates CB1 receptors, which suppresses neurotransmitter release and regulates synaptic transmission. Preclinical studies suggest a potential neuroprotective effect. The neurobiological effects that could protect the brain, I've already listed them before, the antioxidant, anti-inflammatory, anti-amyloid, anti-tau effects. So what are studies suggesting cognitive benefits for cannabis? So there's a primate study I could find where they assessed paired associate visual spatial learning in the subjects. CBD opposed the cognitive impairing effects of THC when administered along with THC in a 1-to-1 ratio. If you add CBD to THC containing therapeutic products, it may help to ameliorate the unwanted cognitive side effects. So this is something to keep in mind. There was a human study I could find where there were 48 healthy participants who took oral CBD at 600 milligrams or placebo 210 minutes before an intravenous THC injection. Would have liked to see that study subject. Episodic memory was poorer relative to baseline in the placebo pretreated group compared to the CBD group. So there is a human study, again suggesting the potential CBD protective effects on memory. It could offset the cognitive-induced impairment from THC. Now let's look at, I wish I had more to show you. There may be other studies, but this is just my gleaning of the literature that showed some encouragement. What about in dementia? So it's interesting that dementia or Alzheimer's with agitation primarily is a qualifying condition in at least 10 states, but less than 1% of medical marijuana certifications. In one retrospective study of 40 inpatients with dementia, they found some reduction in behavioral disturbances and appetite disturbances. There was an open label study of 11 Alzheimer's dementia patients with behavioral symptoms. After 4 weeks, there was a reduction in psychosis, agitation, apathy, and caregiver stress. A randomized control trial using THC for these symptoms had negative results. So clearly, this research is in its infancy. I got to tell you, agitation and dementia is a huge problem. There's no FDA indication for it. Doctors are a bit challenged by this because they use atypical antipsychotics to help with this, but there are black box warnings because of side effects. So we need something that's helpful, but we don't know what to use because there's not enough data or how to use it. Oftentimes I have family caregivers tell me they've tried this or that, and basically I tell them, well, if it seems to be helping, if it ain't broke, don't fix it. I suppose you could continue using that, but it's very hard for me to make recommendations to families about what might help or not. So let's shift now to adverse effects. So I found this review by Sexton and others in the Journal of Alternative Complementary Medicine. And it's showing probably side effects that you're used to. You probably heard about it throughout the day, psychological, cognitive, and physiological. And what's interesting, they have, the histogram bars indicate older, that's purple, middle age is the white, and young is black. Interesting color choices, I don't know what that was about. But what's interesting, for all of these side effects, you see them greater in the younger age groups than in the older age groups. Now, why that is, I'm not sure. It may be that older people are a little more tentative in kind of the dosing that they're using. And in fact, we tend in geriatric pharmacology, we tend to start low and go slow because there's a wide range in sensitivities to medication. So we want to avoid some of these side effects, which can be very serious in an older population. Now, our group, Alison Berggren, Susan Buchheimer, and I did a study that was recently published where we looked at what does early use of cannabis, how does that affect our brains when we get older? So we recruited people who had been heavy users in their teens or their 20s. The volunteers would come in and they'd say, oh, didn't I meet you at Woodstock? That kind of group. And then a lot of them just, kind of used it less as they got older. And we did high resolution MRI, focusing on hippocampal thickness. We had 50 subjects, mean age 67. About half of them were heavy users, and the other half were non-users. And the heavy users became abstinent for about 30 years. So a lot of these people are probably the kinds of people who are starting to use cannabis again. So the results were not great if you were a heavy user in your youth. You had smaller hippocampi, which is not a good thing. Remember, a bigger brain is a better brain. And it's really a cause for concern. It tells you something about dosing and times of life when this might not be helpful. And even the neuropsychological functions of these two groups differed in several different cognitive domains. What other adverse effects do we have to be concerned about? Well, we know as we age, we just don't tolerate drugs as well. There are a lot of age-related changes that occur in terms of the pharmacodynamics and pharmacokinetics. The renal and hepatic changes will change the way we metabolize and also the way we excrete these medications. So you tend to get more prolonged half-lives and greater sensitivity to many drugs, although again, there can be a wide range. Long-term marijuana smoking has been associated with increased respiratory symptoms. Additional reported side effects include loss of balance, dizziness, blurred vision, dry mouth. And I found a study suggesting a possible link between marijuana use and progression of atherosclerosis. So it gets me back to this geriatric pharmacology mantra I mentioned, starting slow and going slow is probably good advice for us. So what about moving forward? Where do we go from here? So I think this brief review suggests a couple things. Given the increasing use among older adults, the likelihood that that's going to increase with greater legalization and adoption, longitudinal, prospective, randomized, controlled studies with placebo are needed. We need to assess the benefits versus the risks. We need to look at the impact of age. We need to look at dosing, the ratio of active ingredients, what's the optimal ratio for the indication, the method of use, how it's ingested or inhaled. And I think for me, priority areas are dementia, people with memory complaints, its impact on pain, sleep, and cognition in general, and these could overlap and be helpful. And also looking at how it might help this population of patients who are demented and agitated. So in the meantime, what do we do while we're waiting for the research to catch up? I think there are several things. Those of us in the room who are clinicians, we want to keep in mind potential drug interactions. So if you have a patient on blood pressure medicines, I'd be concerned about worsening risks of falls if your patient is taking marijuana, for example, in the evenings to get high. If they take too much, they could get up and fall easily, and that can be a huge problem. Also, it can exacerbate drowsiness, and so used in conjunction with other sleep medicines, with alcohol, there can be a synergistic effect that you want to avoid. And it could worsen some of the cognitive problems that the patients are already complaining about. So in conclusion, the research on cannabis and its impact on pain, sleep, cognition, and mood in older adults is clearly in its infancy, and we've got mixed results. The rapidly growing use of cannabis among older adults and limited systematic data, I think, present a pressing need for some systematic study, particularly with randomized controlled trials, and the potential adverse effects on older adults really warrant us using caution, starting low and going slow. Thank you very much for your attention.
I have a question to start off with. You mentioned some of the properties of these other substances that you looked at, Celebrex, curcumin, pomegranate, the phenols. You mentioned antioxidant, anti-inflammatory, anti-tau, and anti-amyloid. And of those four properties, at least in animal studies, have either THC or CBD exhibited of those four properties?
So that's very good. You have a very good memory, Jeff.
It's the cannabis.
You got all four items, and now you're testing my memory. So, my review of the literature, as I recall, THC had all those properties. I think that CBD did as well. I'm not sure of all these properties which really will have an effect, which will be the benefit, but it's sort of a cluster of the kind of ingredients that you want. So it's an issue. It's like anything in medicine. You want to optimize the beneficial effect and try to minimize the side effects. I think that's the challenge. And also I have to, I want to thank you, Jeff and Ziva, for inviting me to join the research initiative, which I think has been a very interesting adventure for me. And I think we're going to do some good work to try to answer some of these questions, hopefully in the future.
Hi, thank you so much for that very compelling talk. I know that within Alzheimer's research, there's a lot of interest in DHA as a possible method for prevention.
Interest in what?
DHA.
Oh, okay. I
Yeah.
thought you said THA. I thought I was
No,
missing something.
DHA,
Okay, yeah.
omega-3s, basically,
Right.
DHA. And I was wondering if that might be a possible outcome of interest for you regarding hemp seeds and how they can contain DHA, and if you've looked at that at all
So
or
we,
are
you know, we
interested.
have not studied DHA that much.
Okay.
There's evidence showing a link to brain protection, and so you know, could have a place. The effect size in the studies I've seen have not been quite as dramatic as what we saw with, say, curcumin. That's one reason. I mean, let me add, with the curcumin study, even though it was very careful, it was long-term, had biomarkers associated with it, it was a relatively small sample because of the cost of the PET scan. So we're going to follow that up with a larger study to convince ourselves that this is real. But still, the curcumin, it's pretty safe. It's like a food. I mean, you can cook with it. So I don't feel uncomfortable telling people about it because it won't cause any harm. But I think there's a lot of stuff out there, a lot of supplements people are taking, phosphatidylserine, coenzyme Q10. These are antioxidant and they have these other effects. The data from randomized controlled trials is limited on a lot of them. Phosphatidylserine has some data, not really long-term data. So it's an area that also is a bit like the Wild West, and we're trying to figure out what's best for our patients.
Yeah, so there was a recent paper, I think in JAMA, about the association between edible cannabis use and arrhythmia.
Wait, yeah, edible what?
Cannabis and arrhythmia, and it was in ER patients in hospitals in Colorado, so it was a select sample. But I don't know if you know of how much work is being done with the elderly and cardiovascular disease risk, or things like other conditions like arrhythmia that have been studied with cannabis, or if you want to, if you read that paper and have any thoughts.
I might have missed that paper, but
it was like within the last month.
Yeah, so I'll look for that. I didn't hone in on that so much. I mean, a lot of these studies, because of the state of the art, they're going to be observational and they're not going to be surprising. If you've got a dosing problem, if you don't know what you're taking, there's going to be people who come in who've had too much. And too much. If you drink too much water, it can kill you. So it's really, I'm not surprised that this is out there. I'm hoping that as we move forward, we'll be able to standardize what people are taking so we can understand it better. But thank you for bringing that up.
Hi there. So my question, first of all, thank you very much for this very fascinating presentation. My question was about the study that you've conducted where you interviewed people that use cannabis chronically. And the question is, I believe there was a similar study out of France maybe a couple of years ago, but the question is whether were you able to hold constant other factors that might affect the health of those individuals, because you might say that people that used cannabis, 50, 60 years ago, 40 years ago, might have used also other substances. Yeah. They're not necessarily, I don't know if they were within the norm. So would that something that you can took into
No, that is a weakness of that kind of study. We tried to control for those other variables as best as possible, such as alcohol use and so forth. But these kinds of studies, they're not prospective studies, and so there's always going to be confounding variables that we can't control for. But that study that we did has been replicated by other groups that have done similar kinds of studies where they look at heavy users in their youth and check out what their brains look like today.
Hi, doctor. Thank you again for your presentation. I'm very curious as to whether there are any studies in the field that currently, outline effects based off of the method of administration of cannabis, as to whether, if you were to distill the desired cannabinoids into an edible format, could that potentially have less, detriments to the aging population or, the population in general?
Well, again, not much out there comparing one mode of delivery versus another. Certainly, if you consume edibles, the likelihood is it's not going to be as bad for your lungs, unless you inhale them. It goes down the wrong pipe. But I would think, once we get to the stage where we can make these kinds of comparisons, we'll see differences. I mean, because the onset of action, the duration of action is going to differ. I'd be fascinated to see those studies move forward. Yeah, and whether they take it with a meal or without a meal, it's going to be very different, yeah.
This is another question on the hippocampal studies. When you were doing these studies, did you take into consideration that 30, 40, and 50 years ago, the cannabis being consumed was riddled with pesticides and microbiologicals? And did you look at any of these pesticides or microbiologicals and look to see if there was potentially an issue in thinning with the hippocampus that could be correlated to that as well? Because I'm very curious about. I read this study recently, actually, and I was very curious about that.
Well, again, another confounding variable. I mean, I think it would be impossible to go back and really accurately find out about it. I mean, one way to look at that might be if anybody did some kind of systematic chemical analysis at the time and compared those products done then to products today, which would be very difficult.
Are you aware of any studies with pesticides and the brain that have been done that could just be looked at alone without looking at the cannabis?
Well, we know that pesticides are not good for the brain. And in fact, so many things, and the question is, how bad is it? What is your exposure? Is it real or not? Over the years, attorneys have contacted me about lawsuits, and there's always that issue of trying to prove a cause and effect relationship. Pesticides, heavy metals, I mean, should you avoid aluminum and so forth. So we're always, even indoor molds, sick building syndrome, there's all kinds, I don't want to freak you out, but there's lots of things that can mess up our brains. And those are good points that, and some people argue, well, the marijuana that was smoked years ago was, in general, not quite as potent as what's smoked today. No? I'm sorry? Well, the cleanliness issue we've been through, right? Yeah. So, but even so, I mean, aren't a lot of people growing it at home, and when they do that, isn't there the risk of contamination? Yeah. So that's going on today.
Yeah, the cannabis on the market today, like California, for example, is very regulated when it comes to testing. So my hope is that moving forward, we're going to see less of these issues in the brain due to the lack of toxicity within the cannabis itself.
I think with these studies, like the one we did, they're just a warning about, and they reinforce this idea that it's, people, they look at these problems like light switches. It's either good or bad, but it's really a rheostat. I mean, it depends on the dosing, it depends on the ingredients, the quality of the ingredients, the time in life. So all these factors come into play. And I caught the end of Tim Fong's talk, and similar issues in the area of sports. It's going to affect children, adults, any age group. These are big issues. And I'm leave it to Jeff and Ziva to solve all of them in the next.
And again, I don't think it's that crazy that the notion that an adolescent developing brain using any psychoactive substance is going to see some detriments. Yeah. And in fact, when we look at animal studies, we see that young mice and old mice respond very differently to THC. And it appears that old mice, it actually seems to improve certain cognitive elements, whereas young mice, it disrupts cognition. So I think that's why.
Studies out saying the opposite of that as well. They were looking at alcohol in the developing brain and cannabis on the developing brain. What they found was that there was no effect on the adolescents who used cannabis, whereas with alcohol, they saw a major reduction in white matter. Yeah. So there's a lot of kind of.
Well, these are great questions. These are great issues. I mean, even though we tried to control for those confounding variables, I mean, it's clear that people who would smoke cannabis heavily in their youth would have different personalities than those who wouldn't. And those personality traits correlate with lots of different behaviors, greater likelihood to smoke cigarettes, to maybe not live a healthy lifestyle, maybe more adventurous, to be a boxer or to play football or something and have a greater risk for head trauma. So these things cross-correlate.
And also, I think another thing that we are starting to address is the notion of risks and benefits. So, I mean, if there are younger folks who are using cannabis for a medical condition, and we are willing to think, and we're willing to conclude that the benefits might outweigh the risks, then that's So we're not throwing the baby out with the bathwater. This is not a binary decision. It's very gray and nuanced. And even with any drug we might give an adolescent, we got to think about risks and benefits, whether it's cannabis or medical.
From NIDA for quality and giving us inaccurate test results in a lot of these situations as well. So that's why we need the schedule to be changed.
So I had a question. It's more, I'm a therapist, psychotherapist. So this is coming from a more subjective point of view about the experience of aging and isolation. And I'm wondering about the impact of getting high, like say one part of a couple being in another place and really into cannabis, and the other one, being basically sober. I think that it actually does contribute to a kind of isolation, and communication is really important as you age, and relationships with the younger generation, with everyone. So I'm just wondering if that's been considered, like the impact of the drug on relationships.
Yeah. Well, I think it's a very interesting point you bring up, and I can understand as a psychotherapist that coming up. And it can work in many ways. I mean, there could be the situation where one person in the couple is sober or not non-user, and the other is a user, and that might pull them apart to some extent. I've seen situations where one person in the couple has been a lifelong user, and the couple gets along great, but then as with age, the other person decides, well, I'm getting these aches and pains, let me try it. And the comment is, my God, he's much looser, he's much cooler now, we're having much more fun with him. But it can work different ways. I mean, it depends on the situation. So it can be isolative. I mean, particularly if people are heavy users, they think, well, what do I need this? I'm just going to play my video game and smoke dope. And one thing we do know is that isolation is not good, particularly as we age. Loners don't live as long. They have a higher risk for dementia and depression. So we don't want people to be isolated. And this certainly could affect their relationships in either a good or bad way.
So thank you so much for this. I just have two other kind of points and questions. One is...
Let's do one at a time so you don't test my short-term memory.
So narcotic use in our older patients, and how we've got a subset of patients who are dependent on narcotics for pain management. And
Wait, state that again? I didn't quite understand it.
our older patients, so I'm going to classify anybody over 50, not that that's old, but I'm going to classify...
Don't trust anybody over 30, by the way.
Right, exactly. So 50 and over, or even if you say 75 and over, and the use of narcotics comparatively to cannabis use. So right now, a lot of the studies we've presented is cannabis alone, but what we haven't done is done a good comparison to narcotics, because narcotics and chronic narcotic use will also cause people to be high, right? It'll also cause people to be unsteady on their feet. It can also cause dizziness. It can also cause falls. And our patients who are more likely to fall or sustain a hip fracture. So comparison between those two different types of medication usage.
So, I did review a little bit of the literature suggesting that when people adopt cannabis use, there's less use of other medications, including opioids. You raise a good point that it really gets to that drug-drug interaction concern. And people who are taking narcotics for whatever reason, and they add the cannabis, or vice versa, that could really increase some of the risk for side effects, which is a big problem.
All right, everyone, give Dr. Small a round of applause. Thank you so much, Gary. Thank you.